So suppose this is here. So when patient comes to you, you either approach the patient from upper motor neuron, lower motor neuron sides, or you approach the patient from the muscle weakness. Suppose there is a weakness in the muscle, predominantly in the muscle. You can think of inflammatory myopathies, you can think of hypokalemias, you can think of myositis, you can think of dermatomyositis. So all these things predominantly occur in the muscle. Hypokalemic periodic paralysis, inflammatory myositis, myopathies, dermatomyositis, and all those things. Once you think that it has got nothing to do with the muscle, then come to your NMJ junction. In an NMJ junction, we have the most common thing, which is myasthenia gravis, or it can be even a Lambert-Eaton myasthenic syndrome. Myasthenia gravis, you know, the nerve starts getting fatigued towards the end of the day, and you look for your acetylcholinesterase antibodies. So other than myasthenia gravis and Lambert-Eaton syndrome, you can have botulinum toxin poisoning, you can have snake poisoning, you can have other neuromuscular junction like OPC poisoning. So when it comes to your neuromuscular junction, try to rule out all these things. Then as you approach up, you get damage to the nerve. In the nerve, you can have porphyrias, various kinds of porphyrias which cause the problem. You can even have vasculitis of the nerve, which is causing the problem. You can have a simple B12 deficiencies, which is causing the problem. So when you approach up, in the nerve, it is porphyrias, vasculitis, B12 deficiencies, or some neuropathies you have. As you go more up in the nerve roots or in the axonal damage, we have our acute inflammatory demyelinating polyneuropathies, which is mostly Guillain-Barré syndrome. As you go further up from there, in the anterior horn cells of the spinal cord, you have poliomyelitis, spinal muscular atrophies, amyotrophic lateral sclerosis, transverse myelitis, epidural hematoma. So you either approach the patient from above or you approach the patient from below and then think of your diagnosis. So if you think there is a progressive weakness which is going in an ascending way, mostly you land up in a diagnosis of AIDP. Or if you think there is a clear-cut sensory level which has been distinguished, you go in terms of your spinal cord transverse myelitis. Or if you think the weakness is not going ascending, it is descending type of weakness, think of botulinism or think of your snake poisoning. Or if there is a history of OPCs involved, go for an organophosphorus compound poisoning. If the patient gives the classical symptoms of fatigability at the end of the day and your NCS with repeated nerve stimulation also tells you that the nerve gets fatigued on repeated stimulation, think of myasthenia gravis. If there is a history of potassium hypokalemic periodic paralysis and patient presents to you with low potassium, even though you can have your AIDP as a diagnosis in the mind, but first treat the potassium. Let the potassium come to a normal range and then think of any other diagnosis other than your hypokalemic related muscle weakness. So what are the classical features of AIDP? There is a history of illness within a nadir of 10 days to 2 weeks. And it is mostly in the form of an aggravating viral illness or upper respiratory tract infection or some diarrhea. And the most important is it is an ascending type of muscle paralysis. So it is a symmetric ascending muscle paralysis. Definitely it cannot be asymmetric. So it is a symmetric ascending muscle paralysis. The diagnosis is mostly by clinical diagnosis or diagnosis of exclusion. Nerve conduction study or your CSF analysis can be to certain extent helpful, but GBS or an AIDP is mostly